for free because we want to make sure everyone has the information they need to stay safe during this global crisis. And I'm so excited that so many of you could make it. I'm going to hand things over to Mita in just a minute, but I did want to go through just a few quick instructions. First of all, we want to make this as interactive as possible. So if you can, start your video. You'll find that feature at the bottom left of your screen. We want to hear from you. So if you have a question you'd like to ask our panel, all you have to do is raise your hand virtually, not like that, because we might miss you, during the Q&A segment of the event. You can do that by clicking the participants, the icon that says participants at the bottom of your screen, and then you'll see a panel open up on the right with the raise hand option. If you're on a mobile device, click the more button at the bottom right and then select raise hand. We'll try our best to get to your question, and when it's your turn, Amita will call you up live and we'll unmute you. I'd like to remind everyone that this event is public, so for your own privacy, I'd encourage you to avoid sharing personal information about your or anyone else's health in this public forum. And finally, if you'd like to support our journalism, please think about joining a HuffPost membership. You'll get access to our comment section, virtual invites to virtual events like this, and a lot more. You can go to huffpost.com/subscribe to find out more. Now it's my pleasure to hand it over to Amita.
Thank you so much, Jen. And hi, everyone. I am so looking forward to this conversation. We are going to start with some insight and learnings from our panelists for about 20 minutes, and then we'll have about 25 to 30 minutes to have a Q&A with all of you. Please hold on to your questions until the Q&A portion. And now I can welcome our HuffPost medical contributor, Dr. Kavita Patel, who is a practicing internal medicine physician in Washington, D.C., and a Brookings Institution senior scholar working on health policy. And along with Dr. Patel is Dr. Stephen Bradley, a U.S. Navy anesthesiologist, clinical medical ethicist, and the host of the aforementioned Black Doctors podcast, which showcases minority healthcare professionals who have overcome major obstacles to achieve success. Welcome to both of you, and thank you for joining us for this important conversation. I'd love to start by launching a poll for those of you that are joining us on Zoom. We'll start a poll, it'll pop up on your screen right now, and it is, how have you been affected by COVID-19? This is a multiple option poll, so you can actually put a couple of different responses here. And while you guys are all filling out the poll, I would love to start with Dr. Patel and Dr. Bradley. I'd love to just start with a really overall conversation about the current rise in cases that we have right now across the country, the recent reports that we're about to enter, quote unquote, the darkest period of this pandemic. Do you have any thoughts on what these next few months could look like for the US?
Sure, I'll go first. Amita, I want to thank HuffPost and just you for moderating this and honestly for tackling a topic that I don't think can get enough discussion. And so I'll just say briefly, 1,600 deaths yesterday and 60,000, probably close to 70,000 hospitalizations today, with, breaking records of numbers of new cases of coronavirus each day, 125 to 130,000, likely to double potentially over the next several months. So I think that what we're looking at, you can call it, people have been debating, is this the third peak, the third wave? Either way, this is the worst phase we've had to date. And at the same time, we're all experiencing kind of the most fatigue and exhaustion, and I think some of the pieces on the poll. So if it helps, Stephen and I practice in very different clinical settings. I'm primarily in an outpatient kind of clinic where in the beginning of the pandemic, we were closed. We went 100% virtual. We have now moved to basically 100% in person. And just yesterday, 2 of our healthcare workers in my small clinic tested positive. So I would say that we're all very scared and we're all very nervous that we're not even, today's numbers that I just told you are not even the worst of what's yet to come in the next several weeks.
I feel like that's a feeling that everybody is having, and it's starting to settle in a little bit more. Stephen, would you like to chime in as well?
Yeah, I would just add that, we're experiencing this pandemic for the first time together. So if we think back to when it first started back in March, we didn't really know what we were dealing with, and everything was shut down. We were on quarantine, physical distancing. and people were wondering, when is life going to get back to normal? Initially, we thought over the summer things would be a lot better, and gradually throughout the summer, restrictions started to lighten up. You remember back to when every state was kind of deciding when they were going to reopen, and life did return some sense of normalcy. It did not return to normal, but certain restaurants were having outdoor seating, and different concerts were starting up, and we're starting to kind of ease up, and considering the different tolls that this was taking on people's mental health, and the feelings of desperation, hopelessness, all of that is understandable. We followed the recommendations of the CDC, Dr. Fauci, and other members, and we went ahead, opened things up, which was appropriate to do so. We were taking precautions, and I think this is kind of the result of that. We've started to mingle again and started to join our friends and family in groups. The good thing, if there is a bright side to this, is that we have had time to increase our production of protective equipment, so PPE in the hospitals. We do have better testing, much better testing than what we initially had, right? We didn't have any testing at all. And now we can actually test for people to see who's positive, who's had positive contacts. And this allows us to know in advance, so we can find those 2 people that are positive in our clinic and isolate exposure. So I think this peak was possibly inevitable, but we had no way of really knowing. Hopefully this next wave can be impacted by the development of vaccines and other measures, and we're getting better at treating COVID, thankfully. So we're just all in this together and learning together.
Yeah, I agree. I feel like I'm learning something new every single day. And we've been learning since March about this virus and the effects that it has. I'd love to launch those results. I know we still have a few people coming into this event, but I'd love to see what the results are right now so we could kind of relate to everyone. All right, we have 71% of you have said that they know someone who's had it, which is indicative. The numbers are up, and they have been up and down for the last few months. 29% of you said that you know somebody who's died of it. 51% have been emotionally or psychologically affected. 23% have been economically affected. And 66% are worried about high-risk family members. And 4% of you have it and recovered. Well, grateful that you guys have had it and have recovered. So it's an interesting sampling right here, but the clear number is 71% and no one knows someone who has it, which is an indication that this is just a widespread virus that is not going away, unfortunately, anytime soon. We're going to launch one more poll just because it is such a topic that can be controversial to certain people. Do you believe wearing a mask helps to prevent the spread of COVID-19? There are obviously differing opinions on this. So I'd love to know what everyone thinks. And while you guys are all chiming in on that, I would love to focus in on the topic at hand, which is the intersection of race and COVID. There are various theories and myths and a lot of conclusions that have been drawn about why Black, Latinx, Native American, Asian American communities are suffering the highest death tolls when it comes to COVID. And we actually got a ton of questions from all of you about this. And Kavita, I'd love to start with you. What have you seen and learned over the last few months about that intersection?
Yeah, I think there's been some myths or misperceptions that somehow that this virus is higher in higher numbers in Latinx or kind of African American, Black communities, a kind of Black, Indigenous, persons of color, and others, because there's some like physiological issue or flaw, or that there is some set of behaviors in those communities which are kind of like allowing for the virus to, quote, spread. It's been fascinating, actually. I work in a more Latinx setting, and patients who have come to me have said, people think that I'm like dirty or I don't take care of myself, and that's why I'm getting COVID. And here's actually the brutal truth. And I know Stephen will have a chance to comment. The truth is that testing access, historically speaking, Latinx and kind of communities of color have had lower rates of primary care, access to hospitals, emergency departments. And so on average, for Latinx persons, there can be a delay in testing And then when we were in like some of the height of the peaks, and we're expecting to kind of go into that now, I'm in the DC area where our numbers have been kind of lower. Our positivity rate has been like 4 to 5%, but it's getting higher and higher. There has actually been a longer turnaround time for getting tests back in communities of color. Access to testing has been a problem. And then access to hospitalization and treatments and ICUs has also been delayed by days. And all of this, for me as a kind of a policy person, has exposed what we've known for decades, that those access issues in general have always been there. And I think what's upsetting to me now more than ever is that, you know, I've done research on this 20 years ago, that like Black people and like brown people are underdiagnosed for mental health, underdiagnosed for heart disease, underdiagnosed for cancer. And it's taken COVID and kind of these stark numbers on screens to have people go, well, why is it that if you're just Black and walk in the door, then you're X times more likely to die of COVID? And so those are some of the, I guess I'll say, myths, realities, and some perceptions.
Stephen, I'd love for you to also dive in on this.
Absolutely. And I completely agree with Dr. Patel. This situation is not new. This is kind of re-exposing what we've already known about our healthcare system and shedding new light on it. And hopefully we will actually listen and make changes as we go forward. The first thing I would bring up about COVID-19 or race in healthcare is what is race. So race is a social construct. It's based upon, you know, when you say race, you're looking at somebody's outward appearance. So it's the difference between a phenotype and a genotype. So genotype is the genetic components of your body. And the phenotype is how those genes are expressed on your skin. So the increased melanin or darker complexion in different people, that's the phenotype of their genetic makeup. And then our societies have taken that over the, last, couple millennium, whatever, and ascribed the concept of race to that. So one of the biggest things when you talk about race in medicine, or why do Black people and the Latinx community have higher rates of heart disease, cancer, COVID-19, is number one, it's not because they're darker complected. It goes back to their genetics. It goes back to what family history do you have of this disease. And as you procreate those different genes, whether it's a predisposition to cancer or high blood pressure, that's in your genetic makeup. And unfortunately, we kind of focus in on the outward appearance, and that's what brings us this concept of race, and that Black people are sicker than their Caucasian counterparts. And the same can be said for those of the whiter Caucasian community, because there's other diseases that are inherent, whether it's hemophilia or a couple other diseases, and it's genes. So that's the first distinction that I would make. So does it change what we're looking at with the higher rates in the Black and Latinx community? So what we see here is those genetic makeups with maybe you had a family history of cancer or high blood pressure, heart disease, and then you put that in a community that has poor access to health. You put that in a community with lower socioeconomic status, and that's in part due to policies that have been present for hundreds of years in our country, where in order to have a job, you have to commute a long distance and you have to use public transportation as opposed to being able to drive and sit in your office or work virtually. So working virtually is somewhat of a privilege that some people unfortunately aren't able to do. You look around the folks that are in the hospitals and the cleaning crews and other more blue collar type of jobs. And in those communities, whether they be darker complected or not, there is a higher incidence of COVID-19 because they weren't able to socially distance like other people were. They still had to use public transportation. They still had to go to work because the way the healthcare system is structured, your job is your health insurance. If you're not working, you don't have health insurance. And folks that are living paycheck to paycheck, they don't have large bank accounts, 401ks. So as you bring in this concept of race, you have to add in social and economic status and those other pre-existing problems that we've had in our country.
Yes, definitely. And I think there's just cultural layers to this as well. I think, Kavitha and I discussed as well prior to this, when there are generations of families living together, and there are cultural aspects to this as well that also are a key variable when it comes to these communities. And
yeah, I should say, Amita, I'm glad you reminded me of that. It's been hard to read CDC guidance for many Asian American families and actually for many families, either who are first generation or people who are just kind of candidly, the way that some cultures have brought up is intergenerational living. So you'll see 3 generations under one roof. And as a result, that means that telling like someone who's COVID positive that they have to isolate. I mean, there's the CDC guidance, and then there's like what I call like what really happens in the real world. And I do think that sometimes people have been asking like, why are the numbers just going up? There's a lot of different explanations, but I can tell you that some of it is the fact that like if you share 3 generations under one roof and you've got little children and you've got people telling one person to kind of isolate themselves from everyone else for 10 days or longer is absolutely unrealistic. And so there's an acknowledgement, and I feel like that exists in everything we do. That like lack of like cultural competency or whatever you want to call it, that exists in our healthcare information, our literacy. It's not just COVID. Again, like I think Dr. Bradley and I are desperate, because if coming out of this we just kind of go back to normal, I will scream. It's just not. It's not going to be acceptable. And I'm hoping that a change in 2021, whether it's political or just people kind of feeling like we've had enough, like that happens.
Definitely. I think there's a lot of question marks for what could happen in 2021. And I want to make sure that we get those poll results for the mask poll first so that we can go into our next topic. Yes. Well, yes, 95% of
this is a definite enlightened audience, because I feel like I've been to places in some of my home state of Texas where people are not necessarily sharing of this opinion to this degree. If 95% of the country, I think Stephen would agree, if 95% of this country wore masks, we wouldn't be here talking about this next wave. I don't know.
I would make the point that they hopefully decrease the spread of COVID-19 as opposed to prevent. Prevent's a little strong, but decrease, and that's right. Still very significant.
Definitely. And I think another obviously hot button topic that has just started to come back out in the news this last week was about vaccines. And there are perceptions and myths about vaccine hesitancy when it comes to underrepresented communities. And so I want to just discuss what you guys have seen and how you have tried to educate your patients and your community and fellow, colleagues of yours about the vaccine. We know it's not ready yet, but it seems like it's imminent. And I'd love to just get both of your takes on that. Stephen, why don't you start with this one?
Yeah, so when it comes to the vaccines, I think there's a lot of hesitancy with most people you talk to, which is understandable because this is somewhat unprecedented how quickly they are developing this vaccine. Usually they go through multiple phases of trials, and they actually still are doing that with this vaccine in development. And by this vaccine, there's probably a dozen or more different formulations that are being developed by different countries, or different companies rather. And although it is being expedited, they're still going through the different trials. So the phase 1 trial where they tested on healthy people has been done for most of these vaccines already. And we're in phase 2 and phase 3 trials. And some companies are running those trials concurrently. So that phase 3 trial is when you get a very broad population and start administering this vaccine to them. And I think some of the health equity and trying to involve and make sure everyone's represented. So these companies have done an outstanding job of trying to recruit diverse participants ethnically, age-wise, and just to really represent the folks that will one day be receiving the vaccine. It's important to note that on either side of the aisle, there are people of color being represented in this research that's being done. I believe her name's Dr. Corbett, who's at the NIH, and her lab is responsible for doing a lot of the groundwork for these vaccines that are being developed. And thankfully, the parallel always gets made between the Tuskegee experiments and other aspects of America's past when it comes to experimenting on people of color. And fortunately, 50 or 100 years down the road, we've changed and amended our ways, and we've done a lot to increase the transparency in these vaccine developments. So I would encourage my patients, the people I talk to, whenever these vaccines are ready, there will be additional information available. I know Pfizer just made their announcement that there's 90% effective, but then there's some paperwork and documentation to kind of back up that claim that is either out or forthcoming. So whenever a vaccine is available, I'd encourage folks to sit down with their healthcare provider and look at the risks and benefits and the efficacy of these vaccines and make that personal decision. We obviously kind of know the alternative to not getting the vaccine is, we're sitting here hoping for herd immunity or what have you. But I am reassured that hopefully in the next couple of months, we would have some vaccines available.
Before you chime in, Kavita, I know that you probably also have some thoughts on this. I'd love to launch the next poll about the vaccine. If we can have that come up, it's real simple. When a vaccine is publicly available and proven to be safe, will you take it? Sign me up, maybe after a few months, maybe after a year or so. Love to know what everybody's feeling right now, given that, as Stephen has just said, maybe in a couple months it might be available. And while people fill out that poll, Kavita, would you like to chime in as well about
Yeah,
that?
let me offer. I agree. We didn't set this up where he and I were supposed to agree on everything. So maybe it's a good sign that we do without having practiced it. But let me offer a different take, because I know this is about COVID and kind of racism. I think, frankly, where the big issue is really kind of in this, frankly, in racism in the distribution of the vaccine. Like, what faith do I have right now based on how we saw testing being allocated, or access to hospitals for treatments? What faith do I have that vaccines aren't going to go to I'll just say it, higher, just the communities that have been kind of well equipped with hospital beds tend to be in higher socioeconomic kind of status, zip codes. But, life in the Bronx looks very different from the Upper East Side. And why is that? Right. My bigger concern is that we're going to have a great vaccine. Nothing's perfect, by the way. Vaccines also, as a reminder, just to Stephen's point about a mask doesn't prevent the virus. The vaccine doesn't prevent the virus. It helps give your immunity system a way to actually fight the virus if you get infected, so you don't have all these kind of catastrophic effects. But I'm worried about the actual distribution. There's the vaccine hesitancy that you mentioned. But what's going to happen when I had patients who were like, "Oh, I want to get COVID tested," and I'm telling them it's a 10-day turnaround. So what happens when I have someone who has a 2-dose vaccine and they're homeless, and I need to make sure that they get their second dose 3 weeks later, and they can't get the Moderna vaccine if they got the first shot as a Pfizer vaccine? So just who's thinking about that? I mean, I don't, that's the kind of stuff that keeps me up at night. How are we doing something to make sure, we've been hearing the vaccine will be free and it'll be, accessible to all Americans. What are we doing for people who kind of, where we feel like there's going to be, I had a Black patient who said something profound to me, because she has COVID, and we were trying to talk about when should she go to the emergency room. And I said something on the phone to her, you should just err on the side of caution. If you're scared, you should go. And she just plain as day said to me, she's like, "I'm a Black woman. I've got 2 little Black boys." She said, "I have no faith that anyone will actually help me." And she wasn't saying it because she's so complicated medically or anything. And I was like, that's that's real. And I don't know, I don't have any way to answer her. I had to give her tips, well, if you go to this ER, they will be more likely to take you seriously. That's the level we're at, and Stephen, I'm sure, I've had, when I worked in the emergency room a long, long time ago, it wasn't rare for me to have families of color who would say to me, they'd come to me because I had this look where they weren't sure and I spoke Spanish. So they weren't sure if I was Mexican or not. And they'd come up to me and speak in Spanish, and they'd be like, "You're one of us. Can you make sure you take care of my family member?" So I worry about the like other side of like the vaccine and the access to treatments. Like we'll have all these great treatments and vaccines, but what happens to people who just can't get them?
Or also just don't trust the system.
Exactly. Which there's a lot of reasons not to do that,
There
I
is.
think. But
There is.
yeah, but you know, I'll say the three of us, like we're hopefully, I mean, people are really, you know, what was great coming out of, if you can say that something great coming out of like George Floyd, it got too many names to count, was that it felt like something was different. I don't know. There felt like there was a change in, I hope, yeah. So it felt like something changed.
I think there's just a larger amount of awareness. There's definitely a huge population who are aware. I think there's been an awakening and a further awareness on that. And it's always going to be helpful because more awareness brings more change. Let's bring up the results of that poll, and I would love to get into some solutions and, you know, positive aspects before we get into Q&A. So we have 42% of you saying sign me up. Great. 40% maybe after a few months, 11% maybe in a year or so, 6% no, I'm worried about the side effects, and 1% doesn't believe in vaccines. So if you guys want to talk to any of those results, please feel free to jump in on that. But if not, we can move on to the next topic.
I would just say it's okay. You know, it's a personal decision between you and your healthcare provider. And thankfully, that first wave of the clinical trials is the part where they really looked at the safety profile of the vaccines that they're developing. In second phase and third phase, they're kind of looking at how effective it is. So again, they're getting more data back if you want to wait a couple months after the first release, because I think what they intend to do is first roll it out as an emergency authorization. I know they've had that in the court systems a little bit over the last couple of weeks when they say this vaccine is X amount effective. In an emergency situation, you can use it. And essentially those folks are kind of being enrolled into the third phase of the trial. So I think it's fine. Don't let anybody bully you into making health decisions or decisions about your healthcare that you're not comfortable with.
I think it's sound advice for sure. I'd love to also, you know, try to have a little bit of hope and optimism with this conversation. And I'd love to see if there's any practical advice or new solutions or ideas that you guys have seen within the industry when it comes to discussing disparities in care. And also, you know, I think the example that you gave, Kavita, about your patient not being trusting of going to a hospital and feeling like she's going to get the best care. You know, we had talked about patient advocates. I would love to make sure we inform our audience about there are some solutions out there. There are some coming out. There are some that already exist, and how people can, you know, best advocate for themselves.
Yeah, I mean, let me broaden it to even beyond COVID. I would say that already kind of on deck for 2021. Well, now kind of we're interestingly enough, we're in kind of an active open enrollment period for insurance plans. If you don't already have, and even if you have insurance through your employer, you can kind of change your insurance. So what's interesting is that I think more and more insurance companies, as well as kind of federal and state governments, are trying to increase like the numbers of people who are kind of different languages and also working within like inside and have trust from different communities of color on how to navigate and enroll in healthcare, because we did see a decline as a result of people losing their jobs. We've had people who've lost their health insurance. We've had people who have like, you know, they're concerned that they will have no access to healthcare. So I think there's an incredible concerted effort. And then there's a lot of like amazing community-based partnerships. So something we talk a lot about in healthcare is how, you know, you can't just deal with healthcare without addressing the fact that like 1 in 5 children are hungry right now because of COVID. And then that's a higher rate in communities of color, anywhere as maybe 2 to 3 children out of 5. And so you can't talk about healthcare without talking about education, without talking about hunger, without talking about, so many of what we call social determinants of health. So, but I would say a bright spot is that we now have like, there's actually ideas about bringing kind of, you know, employment resources for people who are unemployed together with healthcare resources, together with access to like food benefits. And if I could make a pitch personally, I've never been so moved as to when I see people who are hungry and like children who are hungry, and thinking that like, if you have like 5 children of color and like 3 of them go to bed hungry, like that just like breaks my heart. So if any of you have like the will for this holiday season, skip seeing other people and save the money on gas and airfare and donate to your local food bank, because they are filling that void. But what they're doing is working with area hospitals, area clinics. But I think that's incredible. And there are some parts of COVID that I hope stick around forever. I hope some of the virtual care sticks around forever. It's been really convenient for some of our patients. And I hope that this kind of braided or blended interdisciplinary approach, I hope that sticks around too. But it's like a light inside of like kind of a dark tunnel, but it's there.
Yes.
Yeah, I would just add on to that, because that the last part you mentioned, the implementation of telehealth has been amazing. The technology has been around, but having physicians and providers be able to bill for it and receive reimbursements, it's a conversation that should have been brought up a long time ago. And now that this issue has been forced, does it need to be tuned up or fine-tuned and we can figure out the details? Sure. But just having this option available in the future is going to be incredible to increase access to health for all kinds of populations.
I think it's very promising to look at the silver linings that unfortunately this pandemic has brought upon for healthcare. But I think those are really great, movements in the right direction, at least. So now I think we should move into questions and have our audience chime in. First of all, I want to say we were so impressed by the amount of questions. We got 12 pages of questions from you guys for this one event. And so we did try to trailer this discussion to try to answer some of those in advance, but we want to obviously get to you guys and have you ask the doctor something live. So please remember, if you have a question, click on the participants icon at the bottom of your screen and then click raise hand. And please check the chat. If you do raise your hand, you'll hear from our moderators who will put you into the queue, and I can then bring you on live and ask your question. So we will unmute you and ask you to tell us where you're from, and we'll try to bring up as many of you as we can. So let's start with let's see. We have a question. Well, I'll start with a pre-registered question because we're just waiting for a couple more to come in. But we'll do, either of you guys recommend, as soon as there is a vaccine, would you recommend that we vaccinate as soon as it's available?
So I'll just say that's not going to be an option. So we expect in several weeks that Pfizer, the first company with a vaccine, will apply for emergency authorization from the FDA. That is not full approval. And the FDA will likely grant based on an application that is tailored to be very narrow. It will likely only be healthcare workers, essential healthcare workers like Stephen, and maybe not even me. It might be people only who are inside of hospitals because they're the most exposed, and maybe a narrow slice of kind of what I'll call vulnerable elderly and institutional settings like nursing homes. And then what follows, that'll be about maybe 5 to 10 million people in the month of December. And then what will follow that in January, February will be amendments to those authorizations with different populations kind of based on priority. And the priorities have been set by outside groups, the National Academy of Medicine, the American ACIP. I'm having a hard time remembering the name of the
Committee on Immunization.
Thank you.
Practices, I think, is a.
It's an outside committee of experts. So not the federal government, not any kind of federal body, but outside experts. So, but I will say just here and now, we can do it live later if you want. I will take the vaccine when it's available after I get to look at the full data. Right now, all we have is the data from a press release. Science by press release is not one of, I think, our favorites as doctors. So I will look at the full data. We expect those full results to be published in a peer-reviewed journal that is of high reputation in the next several weeks. And I will be looking at it. And if I review it and it holds up, I will definitely be taking the vaccine if someone offers it to me.
Yeah, last month there was a paper in the Journal of American Medicine. It's free, open access. And they just talked about that committee that Kavita just mentioned, the ACIP, and they lay out the guidelines that they're going to recommend to the FDA in terms of rolling out. They didn't talk about the emergency authorization, but they brought up the point that we will have limited amounts of the vaccine initially available, and then there'll be more. And they said exactly what Kavita just mentioned, prioritizing healthcare workers and then essential personnel and the elderly and at-risk populations. And I do plan on receiving the vaccine. Fortunately, with my, none or low comorbidities, I'm at very low risk for side effects, depending on what that information shows. I do plan on taking that vaccine, but the decision is yours to make and between you and your healthcare provider.
Sound advice. That's good. That's all very helpful information. I have a pre-registered question from Jean Hollowell in California. She asks, I understand that there are deep and historic reasons for injustice in this country right now. What are things that individual people can do to make a difference? And I believe she means obviously within the context of this conversation when it comes to COVID.
That's a tough question. It's broad. Obviously we have, this history in our country, which we're just now coming to terms with. I think over the last year, we've really been through a lot as a country. Over the last 4 years, we've been through a lot together as a country. And having to battle this pandemic where we're losing a lot of our loved ones, our friends and family members, and they're being affected, and people are being hit with these economic crises and mental health stressors. Hopefully, I'd like to believe that a lot of us have grown closer together. I know it's been rough, especially with the election and what's been going on recently, but my hope is that together and recognize our priorities more than our differences. And you ask, how can we make a difference? I think just being able to humanize each other. So when I see homeless people or panhandlers or whatever, what have you, I have consciously worked ever since George Floyd, right? Because you watched a video and he looks somewhat disheveled. And it's my deep belief that when you dehumanize somebody, that allows you to treat them differently. So since that event, when I see people asking for money or food, I think about what happened in this person's life that led them to be here, and to try and vibe with that humanity and see them in a different light. And that, I think would help us treat people fair and equitably.
Yeah, that's an incredible sentiment. And I think that would definitely be something that can expand everyone's horizons and hopefully create some change. We have another question here from someone who has just submitted their question. What is the cross-section of people being tested for the vaccine? Is it all Black? Is it all white? What is the mix? Hispanic, Latinx? Does anybody have any information?
Yeah, I do. Stephen, I have that. Let me just give me a minute and I can find, unless Stephen, you have it offhand. I had at one point seen it. Yeah, if you can go to something else, Amita, I will find it and come back. And that.
Yeah, this is a more general question, but I think it still, helps anybody on this. What about the millions of people who don't have a healthcare provider to consult with?
That is a really good question. I don't work in primary care, so I honestly, I would defer that to Kavita as well.
Sure. I mean, I think it's I would say that that's probably the norm. Like even people who have a doctor. I mean, I personally have a doctor, but I'll be honest, like, because I'm in medicine, I'll go to friends of mine and talk about this before I kind of quote, make an appointment and go to my doctor. Why? Because it's a big hassle. So I hope that what everybody can do is think about it goes back to Amita, something that you said about navigators or people you trust. I think the key here is finding somebody who is a trusted source, who actually has some background or expertise like Stephen and I do in training to read clinical trial data. So if you do not have like kind of a personal physician, number one, there actually are now, because of this like burgeoning telehealth business, I have, true story, downloaded myself when I've needed to help get my kids seen quickly, downloaded, some of the apps and some of these services. And I know that they're all kind of getting ready when a vaccine becomes available to be available to answer these questions. The second thing I'll tell you is that don't dismiss kind of, I think, resources like the NIH. Everybody is trying to create kind of like easy to understand resources about data, vaccines, trials. The CDC even actually has like a nice web page on this. I'll put the link in the chat. And and if you don't have a provider or some sort of health professionals, and keep in mind, I'm an MD, Stephen's an MD, advanced practitioners, nurse practitioners, physician assistants. There's a whole kind of like acronym soup of people who can be available. But I want to kind of urge you all to seek out kind of people who can be trusted. And the key factor there is people who will listen. And it doesn't have to be like your assigned PCP. It can be somebody who's in your community. I know that many of us are kind of working with local churches and houses of worship to kind of be available for what we're calling virtual health fairs. If you remember, we all used to do kind of old-fashioned health fairs where you could get your blood pressure checked and kind of talk to people. We're not doing that because of the pandemic. So keep an eye out in your community. I bet there is a resource that you're not aware of. Another good resource, even if you're not age 50 or older, is actually AARP. They're trying to also help coordinate some of this along with the NAACP. There's a number, and then National Council of La Raza, nclr.org. There's a number of institutions that are getting ready kind of when a vaccine becomes available in 2021 to do what I'm describing. So just the key here is kind of validating that the person you're talking to has taken time to read the data. So a key question to ask is to say, have you read the full trial data on this vaccine? And if they don't say yes, then I would kind of use that advice with a word of caution and maybe find someone who has.
Yeah, I know Kavita was looking for those demographics. So I would just mention, and I was reading on for this. Can you hear me okay? And there's over a dozen different vaccines being developed, and each of those clinical trials will have a different demographic. One of the companies is a biotechnical firm out of India. There's a company in the UK, a couple of those, some folks that are working with the NIH. So they're all doing their own kind of protocols. They're probably very similar, but the details are they're going to be different between the different trials. So it's hard to answer that question a little bit until you have a specific vaccine that you're looking at, and then they can kind of break that down further.
Okay, and on the Pfizer vaccine, they had 29% of participants were either Black or Hispanic or Asian. I don't have the breakdown of which one was which, but it's actually considered there. Pfizer is by far, and Moderna was trying to make sure that they had, like at the time, Moderna had about 14%, but was working on, this is about 2 months ago, sorry. But basically the trial manufacturers are aiming for a minimum of about kind of a third between Black, Hispanic, Native American, and Asian. So 29 isn't actually technically a third, but still considered incredible for enrollment.
Yeah.
That's really promising to hear that. And we're going to bring up our first live question. Beverly Rivard, I hope I said your last name correctly. Tell us where you're from and what's your question.
Hi, I'm actually from Wrangell, Alaska, and it's an island community with about, I don't know, maybe like 1,200, 1,500 people. So my question, and we have a large percentage of population of Native Alaskan people on our island in our whole area. So my question was basically like, how is a vaccine, when it's available, going to be equitably distributed among people in different parts of the country, and specifically focusing on the BIPOC community, so that everyone who has, say, high risk because they're working in healthcare situations or any other essential workers, and people who have pre-existing conditions will actually in remote places like I live, will actually have equal opportunity, because a lot of times things don't come to Alaska until like months or years after everyone else gets them, for example. And I know that Alaska is not not unique in that. I've lived in Montana, Wyoming, same kind of thing. When you have lots of people living in small communities in very remote or rural areas, they don't have the same kind of access to healthcare in general. And it seems like because it's not a big population, everybody forgets about you until like a long time afterwards. So yeah, that's basically what I'm asking is, you know, is there a plan for people who live in remote areas or areas where it's hard to access healthcare, and particularly people of color, to be able to have equal chance to get the vaccine?
So I'll start briefly. So the state of Alaska is one of, so every state and territory was asked to submit a plan to HHS for their state or territory's vaccine distribution plan by November 1st. Alaska did. I'm looking at it. It's from October 16th of 2020. And I think some people are kind of, this is a little bit of like how a vaccine gets to people. The vaccines in general are distributed through kind of a program with the CDC so that states can have, to your point, equitable distribution, so that it's not just certain states, red states, blue states, white states, green states that get it. It is equitably distributed. However, the flu shot has on a given year like a 40 to 35 to 50% of people get the flu shot. We are hoping and expecting a higher proportion of people want a COVID vaccine if it's safe and effective. So your exact question is why the federal government does play an important role in kind of getting these plans so it can prepare to think about what it needs to do to then hand off, like kind of Pfizer can't just send vaccines to CVS. It all has to be done through like coordination with the states. I will tell you the biggest hiccup, not just what you said about Alaskans and some barriers because you're just physically so far away. Hawaii also suffers some of the same issues along with some other territories. The biggest problem with these sets of vaccines is they're considered highly unstable because of their incredible ultra cool requirements. And that creates a supply chain distribution. Imagine making sure that as the vaccine, which is manufactured, I actually don't know where it's been manufactured, but wherever it's manufactured has to leave the facility in a negative 70 degrees Celsius container on whatever FedEx truck or ship or plane and get to your kind of, local distribution center for whatever is identified by the state of Alaska as your distribution center. And then you need the documentation for that second dose as well. So this is what I mean by my worry is not about Pfizer doing enough trials, Pfizer getting enough people of color. What you just described is my worry. And this is where I worked in the federal government. I actually do believe the federal government plays a large role in ensuring that this is done equitably, because who else is going to do it? It should not be left up to just individual states. And we saw some hiccups with the initial rollout of the treatment remdesivir, which is now FDA approved for COVID. But I think hopefully we'll learn from that. But it is one of those things that I am concerned about. And by the way, like I said, every state had to submit plans. So if anybody is curious, it is easy to Google, Alaska COVID-19 vaccination plan, and every state has one. And whether it's adequate or not is another question. But that's what it is.
Thank you so much for your question, Beverly. We want to get as many of you to ask your questions as possible. So I'm going to get to our next live question, Denise Chaplin. Please let us know where you are and what your question is.
I'm in London, UK. And here it is nearly 11 o'clock at night. So if I look a little tired, it's been a long day. My question really relates to the commonalities and differences that we have in the UK and the US. Here in the UK, we do also have a higher incidence of deaths, fatalities in the Black and Asian minority ethnic communities from COVID-19. Many of those have been key workers all the way through the first phase of the pandemic. People including transport workers, but also nurses, carers, doctors, consultants, people at all levels. We have the NHS in the UK, so access to medical care is very different from the US. So I don't think that we can necessarily call that a factor, particularly as some of these colleagues will have been NHS workers. But I'm wondering if there's research being done that's being shared and it's being done across both our communities, because we have as diverse an ethnic mix, but different from yours. And I have many colleagues who are teachers now, who obviously have got children are back in schools, and they are also, as key workers, at great risk as well, who are very concerned to be learning, not just from our own little island community, where we have our own problems like Brexit and things like that to add to our fun, but also across the world. And I think that your communities and ours are probably the most similar in terms of this vast mix of people of different generations, different skills, different talents, different jobs. And I mean, what I'm hearing from yourselves, it's just so reminiscent of what we're hearing here. That's my question.
Awesome. That's a fantastic question, Ms. Chaplin. Thank you for staying up so late to join us. And that's would be incredible. I have not seen a head-to-head comparison of the data, but it'd be nice that over in the UK, you seem a bit controlled for the access to care, but then it's such a multifactorial problem with the socioeconomic status, the living situations, as Dr. Patel mentioned earlier. I will take you all the way to rural Milwaukee County in Wisconsin. I just looking up a paper, and they corrected in their study for all the different factors and just looked at race, which I alluded to earlier. And they found that in their county, 46% of the people affected by COVID were African-American. However, they only represented 27% of the population, and 73% of the deaths were 73% of the deaths were African-American. And it goes back to, in part, if you have a family history of heart disease, stroke, asthma, that does increase your susceptibility to this disease. And as in the UK, I'm sure you have a large population of foreign nationals or immigrants who have moved to your country, and their family history, genetic makeup, whatever diseases run in their family may be increasing their risk factors for this virus as well. But I would be very interested in seeing a comparison of our data from the states and across the pond.
Thank you again for that question. Let's get to one more live question from Joyce. We are going to unmute you right now. Let us know where you're from.
Thank you. I live in southeastern Vermont in a village, and my question is really about telehealth in a rural community through northern New England, but all over the country. The access to the equipment and the connectivity really prevents people from accessing telehealth. And I'm wondering if there's any consideration of that. It would be great if it were accessible to everyone. I'm not seeing that it is.
Yeah, you are so spot on. And just maybe last week or 2 weeks ago, the FCC, keep wanting to, I'm getting the acronym wrong, but Federal Communication Commission just released $100 million in grants that are supposed to be directed towards kind of community-based organizations for the purpose of enhancing broadband access with the goal of doing, kind of telehealth. It's one of the many perverse examples about healthcare that have disturbed me, that I think we call it the last mile in broadband access. That last mile has translated to, less people being able to actually get a hold of a healthcare provider. And I think vice versa. North Dakota, which has been a state that has had some of the most dramatic numbers around COVID, it has a governor that does not believe in masks, yet it has just authorized nurses and healthcare workers who are infected with COVID to be able to kind of work outside of the COVID wards and go to other hospitals because they have such a severe shortage. And nobody is talking about the fact that going into this pandemic, it had some of the worst broadband access in the country. and that many people are, hundreds of miles from a hospital, not like tens of miles, but teens of miles. So I think it's a great note to end on, because I would say that while $100 million in grants is better than nothing, we have a lot to do. And why is it that other countries have made Wi-Fi access a public good, just a public good? And so why is it that we are still kind of denying, and in communities of color, it can be as high as 2/3 of communities of color don't have reliable Wi-Fi access, or kind of an ability to have a stable internet access to do something like healthcare or anything on. That's crazy, insane in the United States. And I would say in the world, people look at us and can't make sense out of it.
Yeah, it is a little mind-boggling, honestly. And I want to make sure we get one more question. We're about to wrap up, but I want to get one more question here from Maritza Campos. We're going to unmute you. If you can ask your question, that would be lovely. Maritza, are you there?
Can you hear me?
Yes. Hi, welcome. Thank you for joining
Hi,
us.
this is Maritza. Thank you. I divide my time between Florida, Central Florida, and the Finger Lakes in New York State, both kind of rural communities where I spend my time. But my question is really related to long-term COVID. Many of us that had COVID early on are still suffering. I mean, thousands, I know of thousands of people that are still suffering from consequences. For example, I had COVID in April and I still can't taste or smell anything. And I actually almost burned down my house because I put something on the stove, forgot about it, and there were flames coming out. I couldn't smell the smoke. So the problem is that you have to have many tests to make sure that all your organs are working correctly when you are having all these symptoms all these months later. And I'm very fortunate because I have TRICARE, which is military health coverage, and Medicare. But a lot of younger people are not as fortunate. And there isn't even a coding for putting all your COVID long-term symptoms and exams coded together. And also some people are getting stuck with thousands, tens and hundreds of thousands of dollars. I mean, I've had 4 MRIs on different parts of my body. I have had 3 echocardiograms in different parts of my body over these 9 months because of all the different symptoms I had. Now, my health coverage covered most of it, but a lot of people don't have prime health coverage like I have, and they're getting stuck with all these costs.
Yeah, I guess just because we're a little bit short on time, Maritza, I don't want to cut you off, but I think maybe the question is for those people who have suffered from COVID and have longer term effects post-COVID diagnoses, since this system, probably the healthcare system, wasn't totally prepared for any of this. What solutions and what things have you been seeing? Stephen or Kavita, whoever feels like they have something that they've been seeing that is progress in that aspect.
I'll be brief. I'll say that, whether people have been calling it long hauler or kind of post-COVID syndrome, chronic COVID syndrome. I mean, we're not able to keep up with like what your example, Maritza, we're not able to keep up with what's actually happening on a practical basis. And so, yes, people are getting surprise bills. Yes, people are not being diagnosed or kind of encoded accurately. And I am seeing now patients who are coming in from March and April who are still having the same type of sequelae you're describing, and seeing people who are coming in with like new cases. So it's kind of this like crazy intersection. And I think what people are trying to do, this gets back to like sharing lessons with like other countries. I think people are trying to kind of share data from other countries about, symptoms we didn't understand. The loss of smell and taste is a great example, and how we can incorporate it. But we're reacting. I mean, and so I guess I'll close by saying like, Stephen's hospital, my hospital that I'm staff at, like we are submitting data to the federal government. It's like going into some big black box. I would love to see a kind of something that turns around and offers like Stephen and I kind of at the point of care, like a little bit more information about what we're kind of walking into. Like that if it's a patient like Maritza, then we understand that she's, if she's still having symptoms X months later, she's likely to have X, Y, and Z as well. And it can give us a little peek into what we need to do. I'm hopeful that'll happen. I've been wondering why it hasn't happened sooner, but I'm hopeful it will happen. But until then, we're going to unfortunately have what we heard about.
And Stephen, I just want to make sure that you can chime in as well before we finish up our event today.
I think Dr. Patel kind of summed it up, but unfortunately, we don't know a lot of the answers to this question. We know a lot more than we did back in February and March, but unfortunately, there's still a lot that we just don't know.
Yeah, but I do think that I will say, to wrap this all up, I think that it is super valuable to have both of your insight today. And I think hopefully we've helped some of you all with some of the questions you've been having, and hopefully giving you some solutions to help everyone. We'd love to hear what you think about today's event. We take your feedback very seriously and make changes based on what you tell us. So please fill out our short survey. We're dropping it in the chat right now. It should take less than 5 minutes to fill out. Please tell us how we did and what future events you would like to attend. Ucilia is dropping that link right now, and we'd really appreciate it if you could take a few minutes to fill it out. Thank you in advance for that. First of all, I need to thank Dr. Stephen Bradley and Dr. Kavita Patel for joining us. We were so very happy to have you here. We are also very happy to have all of you join us as well for this conversation. These are free and open to the public because we know it's such an important topic, and it's of everyone's interest right now, of course. If you enjoyed this event, we have many more planned, and we encourage you to sign up for HuffPost membership. It is free for basic membership, and it gets you invitations to all of the events like these, and many of which were open to members only, actually. So this one was open to the public, but we do have some that are just members only. And we also have free and discounted tickets for basic members as well. Our next event is about resilience in the workplace, and it's on December 3rd. So please mark your calendar for that if you're interested in joining. And being a part of the HuffPost community, if you're a basic member, it means you'll be able to comment on stories and participate in online forums with journalists and experts like Dr. Patel and Dr. Bradley. If you want to financially support the work we're doing, you are in the position to do so. Please consider joining HuffPost Plus as a monthly or annual paid member. Go to huffpost.com/subscribe to learn more. They're going to drop that link in the chat as well. But it's huffpost.com/subscribe, and you can learn more about all of these tiers, and you can cancel at any time. So there's no commitment here, but we obviously appreciate all of your support. Thank you again for attending and for all of these amazing questions. Apologies we couldn't get to all of them, but the turnout and the excitement about this definitely is an indicator for us that we might need to do more conversations like this in the future. We hope that you enjoyed it as much as we did. Thank you all. Please stay safe. Be sure to wear a mask, social distance, and do everything you can to stop the spread. Thank you all. Have a good day.